Hello, good evening everyone. I'm Dr. Rajiv Kovil here, and I'm here to answer all your queries about diabetes. We know how diabetes has become an epidemic in our country, and unfortunately we have close to 70 million diabetics in India. It's almost 7 crore. Prevalence rates are close to around 15% of our population has type 2 diabetes. And the problem with diabetes is that diabetes gets premature complications. And that's the reason that we need to treat diabetes. And diabetes has a lot of cardiovascular risks it carries. And our whole intention of treating diabetes is not just treating the blood sugars, but also preventing patients from going into complications. And the average age for diagnosis in India is at least 15 years earlier than people in the Western population. So the average age is close to around 42 when the Western population usually gets diagnosed beyond 55 years of age. So we have premature diagnosis of diabetes. We also have premature complications of diabetes. So the time is that we need to kind of medically, socially and economically, there's a need for all of us to gear up and to prevent complications of diabetes. And this is one such attempt where we are going live, and probably we could have some interaction, good interaction over how we can prevent diabetes, how we can prevent complications of diabetes, how we can help families with diabetes overcome the complications and the burden of diabetes. Because apart from just the complications, diabetes also poses a huge economic burden on the family. And it's important that we kind of know that diabetes can really cause a huge hole in your pocket. So that's extremely important that we need to also understand that how do we prevent the economic burden of diabetes as well. So in India, unfortunately, we do not have a lot of structured care across the country. And that's the thing that we lack. We need our diabetic patients to kind of get more learned, I would say, get more literate about health, and not just Google the complications or Google about medications, but actually get literate about health and what are the various preventive measures that one can use to prevent diabetes, and also the various preventive tests that one can do to prevent complications of diabetes. Because if we are able to pick up complications earlier, we are at a much higher chances of kind of preventing them, treating them, curing them, or at least delaying the complications of them. So we have a question from Pravina which says that a doctor has put her on insulin. So does this mean that I have poor diabetes control or poor health? Actually, no, Pravina, that's not true. Insulin can be given for multiple reasons. Very often it's given when the drugs don't work, but it can also be given if you have an early sign of complication, or you have severe weight loss, or suppose you are undergoing any kind of procedure. If you're undergoing a procedure, if you're undergoing a surgery, that's the time when we put patients on insulin. So it doesn't mean that once on insulin, you're always going to be on insulin. That's a myth and misconception. So it's not true that we have to be on insulin constantly once we are on insulin. I hope I have answered your query. We have a question that why is foot care so important in people with diabetes? We need to understand that a person walks for approximately 80,000 kilometers in his lifetime, and the foot is put at a huge risk, and almost 3/4 of all non-traumatic amputations across the globe is related to diabetes and diabetic foot. Diabetic foot ulcers usually occurs in approximately 20 to 25% of patients in their lifetime. And it's one of the most common causes for amputation. And we can prevent amputations, and once a foot gets amputated, it's a handicapped life, which also means loss of quality of life, loss of payment, and so many other things. So foot care is the first preventive step in preventing a diabetic foot complications, and foot care which can be which is a very simple form of education to patients to how to take care of the feet, how to wear appropriate footwear, how to cut nails, how to not do certain things at home in terms of massages and hot fomentations, and usually it's a very minor trauma which causes a diabetic foot. So foot care can go a very long way in preventing complications related to diabetes. The diabetic foot is a huge complication rate, and we've had a lot of sessions, and we've also launched a project called as ZAP, which is Zero Amputation Project, which looks at also educating doctors across India on how one can identify foot at risk earlier and probably prevent complications related to diabetic foot. So this is, foot is a very important complication in diabetes, and I hope I've answered your query on diabetic foot. Now, apart from diabetic foot can get affected because of blood supply and also because of nerve-related issues, and usually both these complications are there, and they kind of synergize together and cause a complication, which is diabetic foot infections. And diabetic foot infections can range from a small infection to a small ulcer to a major gangrene, which can threaten the foot also and threaten the life of the patient also. So diabetic foot is something that we need to prevent, and we can adequately prevent a diabetic foot infection by putting foot care into our day-to-day management as such. In terms of other complications of diabetes, heart disease, heart failure, retinal changes, that's the eyes, retina, and the kidney are the four major other complications related to diabetes. And heart failure has also emerged as a new complication of diabetes. And many patients, close to almost 3 out of 10 patients, would end up with some form of heart failure. And it's very important that nowadays we have drugs which can actually prevent or probably prevent new onset of heart failure. And it's something that we need to work on. And today therapy has changed from being just sugar-centric and getting the blood sugars down to using appropriate drugs which prevent complications and in turn also reduce low sugar and also reduce weight, and also kind of it can be economical in the longer run. So today we have a lot of research done in the field of diabetes, and the treatment has revolutionized as a 360-degree change from just controlling blood sugars to kind of controlling a lot of complications and using appropriate drugs and having an individualized and tailored therapy for patients to prevent diabetes. Heart disease is another major complication, and many patients do not recognize that probably diabetes per se is equivalent to diabetes, to heart disease, and that's why we need to control, you need to prevent heart disease by using appropriate drugs and probably preventive drugs as well. We have a question that what are the recent approach to manage insulin sensitivity? Manage insulin sensitivity or manage insulin resistance? I would tell you both. Insulin resistance, that means where your insulin doesn't work the way it is supposed to and actually does not channelize the glucose into muscle and fat and actually makes them store it as fat, is insulin resistance. And insulin resistance is the main pathophysiological defect in all patients with diabetes. Insulin sensitivity of a patient kind of reduces with age, with obesity, with wrong eating patterns and sedentary lifestyle. The insulin resistance and insulin sensitivity are linearly related to exercise and diet and weight. So insulin resistance can be cut down by obviously the exercise and a good lifestyle change, and that remains a cornerstone of therapy. Today we have a lot of insulin sensitizer drugs, and those drugs help in the working of the insulin or sensitizing these insulin to work in our body, and that's the majority of the way that most of these drugs work. The drugs work by making our insulin more sensitive to tissues, to especially to the liver, to the fat, and to the muscles, and that's how these insulin sensitizers work. And they continue to remain cornerstone of therapies for close to 5 to 6 decades. So insulin resistance as such is the first defect which kind of progresses a patient from normal glucose to impaired glucose to pre-diabetes to type 2 diabetes. So if we can prevent insulin resistance from childhood itself by probably recognizing childhood obesity, by encouraging children itself to exercise and eat the right diet, then probably we may not have insulin resistance and these kids may not progress to insulin resistant adults and then finally progress to type 2 diabetes. Insulin resistance is also the most common pathophysiological defect for teenage girls with polycystic ovarian disease, and polycystic ovarian disease is the most common cause for irregular periods at that age group. Probably 80% of girls who have irregular periods would have polycystic ovaries, and insulin resistance can be tackled there by weight loss and by good exercise, and that remains to be the main treatment for insulin resistance as such. Drugs do help also in insulin resistance. So as I was touching upon the complications of diabetes, the other major complication of diabetes is chronic kidney disease and kidney failure. And there are a lot of preventive steps, preventive tests and preventive drugs that both type 1 and type 2 diabetics need to use so that one can prevent the progression from a normal kidney to a diabetic kidney disease. And today we have a lot of research done in diabetic kidney disease, and we have a lot of drugs which can help you in preventing the progression towards diabetic kidney disease. And approximately, if any of you all visit any dialysis unit across India, you would see that 9 out of 10 patients who are on dialysis have been afflicted with diabetic kidney disease. So it's very important that we do preventive tests in terms of what is called as urine albumin creatinine ratio, then just and not just the blood profile for the kidneys. And we can actually detect the progression and also kind of propagate what will happen in future by doing preventive tests and identifying those patients who have these complications and then putting them on appropriate therapy so that you can prevent their progression towards diabetic kidney disease. The other major complication in diabetes is the retina. Retina is the largest, diabetic retinopathy is the largest cause of blindness in the world, and it's extremely important that one need to screen for retinal changes, because retinal changes do not usually come in and they do not give any much of symptoms. So it's extremely important that we screen for the retina on a yearly basis, even if you don't have any symptoms, and that's the only way that we can prevent retinal damage and retinal edema, which is also very, very commonly seen. We have a question that how much of physical activity do I have to do? Actually, the recommendation is to do close to 180 minutes of aerobic activity per week and 2 resistance training per week. So you can split it into maybe 45 minutes 4 times a day, or maybe 30 minutes 6 times a day. That's up to you. But you should not be skipping any amount of aerobic activity for more than 2 days. So that's extremely important. Probably your metabolic rate comes down when you do that. So 180 minutes of physical activity per week, aerobic activity, and 2 resistance training is what is recommended to be doing. If one is physically active and one has been screened for all other complications, your foot is fine, your heart is fine, then there's no upper limit to activity. You can go up and you can exercise and do your aerobic activity much to an endurance level, which could be almost 85 to 90% of your maximum heart rate. Usually maximum heart rate is 220 minus age. So if you can go up to 80 to 90% of your maximum heart rate and maintain that for a good 25-30 minutes, that's a good amount of endurance activity. But all this needs to be phased over a period of time. You cannot just start, and exercise needs to be phased over a period of 6 weeks to 10 weeks. We have a question now, I know that diabetes education is important, and what is it and how do you exercise? It's a very good question, because in the Western world, there's something called DSME, that's diabetic self-management education. Now, DSME is something that we as doctors and our staff, which involves our nutritionists, our educators, everyone needs to be doing some amount of diabetes education. And diabetes education can be structured and has to be in a structured format. You can't bombard everything about diabetes to one patient. So you need to identify what probably is the patient's need. Sometimes it could mean from a simple thing like foot care to identifying the sites of insulin or how do you inject insulin, to something like how do you store medications, how do you travel with insulin, to various kinds of tests and preventive tests that we need to do. So diabetes education is a huge, and it can make a huge difference in a patient's lifespan. And a more literate and a more health literate patient can prevent a lot of complications by identifying a lot of signs and symptoms which we would inculcate in them on how to identify these signs and symptoms, and probably they can touch upon this on a day-to-day life and probably pick up certain signs or certain complications early and come for treatment early, and that's what diabetes education is all about. So diabetes education is something that needs to be done periodically. You need to reinforce a lot of diabetes self-management education. It could also be how one could titrate, if you're on insulin, how do you titrate your insulin? If you have to check your blood sugars, how do you check? Because that also needs to be structured, and we have a lot of research on that itself, that how do you structure blood sugars, how do you check for blood sugars, and what do you do with a glucometer at home? How do you optimize the use of these glucose meters? And when you check, what do you check, and how do you change your dosages based on that? So that's an algorithm that is to be taught to patients who are on insulin, that how do you check for your blood sugars, in what way can you kind of change and do a little bit of self-management at home itself without kind of causing any complications or any kind of low sugars onto you. So this is something that that needs to be taught. So that's why I said that diabetes education is something which we need to structure over a period of time, and it needs to be individualized and personalized based on what the patient's needs are, and it cannot be that the whole education is given to all the patients. So access to it, as you said, that all the professional organizations, whether it's the American Diabetes Association or the Indian Association, which is called as the RSSDI, has a patient portal as well. You can access those information. It's better to access them from these official association sites so that you do not get wrong information and you do not get wrong practice into your lifestyle. And these are easily available digitally, and one can download these things and kind of put them into practice. And that's the more easier way to kind of access these information. But again, as I said, that there's a whole sea of information there, the world of information there, and you need to kind of prioritize that what type of information do you need. Do you need some information about diabetes at the eye? Is there information regarding diabetes at the kidney, diabetes and pregnancy? Pregnancy is a huge challenge where if you have diabetes and pregnancy together, and that itself can cause a lot of issues, and it's important that we identify pregnancy and diabetes and treat them. I'll come to pregnancy. Can I drink alcohol? If you are a diabetic, if your feet are normal, if your liver is normal, you can have moderate alcohol intake in a week. It doesn't mean daily drinking, but one needs to understand that diabetics are very prone without alcohol intake also for what we call as non-alcoholic fatty liver disease. Almost 35% of chronic liver disease or liver cell failure, as we call it, is related to non-alcoholic fatty liver disease, and which is driven by diabetes. So all the metabolic abnormalities that you see in a diabetic drives the epidemic of non-alcoholic fatty liver disease, which drives the epidemic of cirrhosis of liver or liver cell failure. So it's very important to see that you do not have nerve problems which can increase because of alcohol. You do not have a liver problem related to diabetes. You can take moderate alcohol if it's there. Alcohol can also make your sugar go up and down. It can, if they are empty calories, so some sugars can go up. If it can also make your sugar go down. So it's extremely important that on a social platform, I cannot recommend how it's to be done, but probably you could go and meet with your doctor and he would know your complications and yourself and what are your basic parameters, and he would be the right judge to tell you that how much alcohol could you actually drink. Glimepiride and metformin, does that have complications over the long term? No, you have to realize that any drug that comes into the market goes through at least a decade and a half of research before it comes in. After it comes in, it goes through a lot of cardiovascular pharmacovigilance across the globe. Unfortunately, it's not there in India, but across the globe, every drug is being monitored. So there are no complications, life-threatening complications, or with the combination that you have said. Long-term metformin can cause some amount of B12 deficiency, so you may have to take a B12 supplement. Low sugars may be a complication with glimepiride. Hypersensitivity, that means allergic reactions, can be there with any molecule. So that is kind of to one particular person. It may not be for another person. It's more individualistic. So there's no problem in the combination that you asked me about. The other question is that can women with diabetes breastfeed their babies? Obviously, yes. Women with diabetes can breastfeed their babies. Certain drugs are not to be used during lactation, but majority of the drugs can be used. We usually would recommend insulin and probably metformin during lactation. And women with diabetes can breastfeed their baby. There's absolutely no problem. There's a question that I've just been recently diagnosed with diabetes and what should I do? Whether you're recently diagnosed or you've been a diabetic for long term, you need to identify that diet, exercise, and lifestyle changes and pattern changes are the cornerstone of treatment for diabetes. So one becomes a diabetic because some of the habits may have been wrong. It could be patterns where we eat large meals at some times and we starve during the day and probably end up with high blood sugar swings. It could be obesity, it could be sedentary lifestyle, it could be stress. So you need to identify them and probably treat them, and that's something that you need to put into practice. And as a new diabetic, one should get a lot of health literacy about diabetes, and that will go a long way. How frequently one needs to check his blood sugar post 40, and are men more vulnerable to diabetes? There's no gender-related differentiation about vulnerability to diabetes. There are certain gender-related complications or sensitivity or insensitivity to certain drugs. Above the age of 40, I would recommend that above the age of 30 in India, because the average age for diagnosis is 42. Above the age of 40, one should do a yearly checkup for your blood sugars and do an HbA1c, so that we can actually kind of diagnose whether the patient is progressing or not. Just a fasting PP may not be enough, so you may require to do an HbA1c also yearly to kind of see whether you're progressing in your diabetes front. The other question, how should hypoglycemia be treated? Hypoglycemia depends upon whether you have a mild hypoglycemia, moderate or severe. It depends whether the patient is conscious, or the patient is drowsy, or the patient is unconscious. So if you have a mild hypoglycemia, probably 4 teaspoons of sugar or glucose in a juice would be fine. That should also be okay for moderate hypoglycemia. If the patient is drowsy or patient is unconscious, then ideally you should shift the patient to the closest hospital. Do not try to force feed the patient if the patient is unconscious or drowsy, because you can have an aspiration pneumonia into the lungs, so that should never be attempted. There's an injection called glucagon, which can raise the blood sugar in 10 minutes. So if you have access to the injection glucagon, or if you are a patient who goes into repeated low sugars, then probably you need to keep the glucagon injection at home, and as soon as the patient goes into a low sugar, inject glucagon and the blood sugar comes up immediately. So glucagon is something that you can do. Hypoglycemia, most importantly, has to be prevented, and if you are a patient who gets repeated hypoglycemia, there needs to be a change in therapy. There also needs to be a lot of change in patterns, and that has to be individualized at your doctor's level. The other question, what's the difference between carbohydrate and sugar? Carbohydrate and sugar. Sugar is a carbohydrate. Sugar, by what we mean is sucrose, is a disaccharide. It's a form of carbohydrate. You have simple sugars to complex carbohydrates. So carbohydrates and sugar is almost the same. So a lot of patients believe that if I don't eat sugar, I will not get diabetes, or if I eat a lot of sugar, I will get diabetes. Both of them are myths and misconceptions itself. It's the overall caloric intake and the overall carb content. Approximately in India, each meal is approximately 80% is carb, and that's something that we are a huge carbohydrate eating population. So even if we don't directly eat direct visible sugars, there's a lot of invisible sugar which is going into you, and everything that you can think of, whether it's a farsan or a main food, has got a lot of carbs, and that's probably the reason that we need to have a low carbohydrate, a higher protein, a higher roughage intake in our diet. The other question is diabetes reversible? Over the last few years, a lot of questions have been asked about diabetes being reversible. Diabetes, if a patient who is on therapy goes off therapy and is able to maintain his blood sugars in good control, that is not called as a cure or reversal of diabetes. That's more like a marketing term. It's called remission of diabetes. By remission of diabetes, you mean that the patient's symptoms and signs of diabetes are no longer there, and patient's blood sugar are in the normal range without medication, which is possible with a very low caloric diet and a high amount of activity. There is a chance that one can go into a remission very early on in diabetes. By earlier on, I mean that the patient should be less than probably 5 years of diabetes. If you're a long-standing diabetic, your pancreatic secretion or the pancreatic function has gone down so much that probably you will not get any benefit here. But very early on in diabetes, if you are able to put in a good therapeutic lifestyle change, you may go off therapy, but that doesn't mean that you cease to remain a diabetic. You continue to remain a diabetic, but you have gone into a remission where you do not require medication. Even when we do a bariatric surgery today, the patient goes into a remission for close to 10 years, really early on in diabetes. If you do a bariatric surgery or a gastric sleeve or a banding, where you reduce the circumference of the stomach or you bypass the stomach, you are able to get a better functional capacity of your pancreatic beta cells, and you go into a remission which would last from anywhere between 5 to 15 years. So that's still not a reversal of diabetes. It still continues to be called as a remission of diabetes, and that's something that one can actually attempt in life in terms of going on a very low caloric diet and exercise, and that can really help you in probably getting into a better system, and probably also preventing the long-term complications of diabetes. So before we were talking about diabetes in pregnancy, and today as the average age of pregnancy in India has gone up, ideally it should be less than 25, but we know pregnancies are occurring at a much higher age groups, and that's probably the reason that we're getting a lot of complicated pregnancies, which could be diabetes in pregnancy or even blood pressure in pregnancy. And diabetes in pregnancy is is a period that one needs to be monitored very well, one needs to take care of oneself very well, and one needs to be under expert guidance during diabetes and pregnancy, because the targets that are there for diabetes in pregnancy is much lower than the targets in a non-pregnant situation. So it's very likely that a few weeks of glycemic changes or blood sugar changes and you can complicate your pregnancy. So it's extremely important that diabetes and pregnancy should be managed by experts in diabetes, and they know the targets and how to achieve those targets and how to monitor patients on a regular basis. And that's a huge complication in diabetes, where we need to make sure that women in the pregnant age groups, women who are desiring pregnancy and who are diabetics should have a preconception counseling itself, so that they know what to expect during pregnancy, and they kind of have a mock exercise on how they would manage themselves during pregnancy, and that goes a long way in preventing the outcomes related to the child, to the fetus, to the child in diabetes and pregnancy. So that's something that one needs to keep keep that in mind. Some other questions also, I believe, was how is diabetes diagnosed? Are artificial sweeteners? What are good travel foods for people with diabetes? Interesting questions. Diabetes can be diagnosed with just fasting and a post-lunch. Fasting blood sugar of more than 126 is diabetes. A post-meal blood sugar of more than 200 is diabetes. A random blood sugar of more than 200 is diabetes. The average blood sugar, which is called as the HbA1c or glycosylated hemoglobin, more than 6.5 is diabetes. So you can diagnose diabetes in any of these ways. You can also diagnose diabetes by doing oral glucose challenge test, which would be a 2-hour post 75 grams of glucose. Are artificial sweeteners safe? Yes, artificial sweeteners are safe. Most of them have gone through the US FDA for all their trial applications, and they are safe to be used, and most of them are heat stable as well as cold stable. Only problem with artificial sweeteners is that what I generally advise my patients is that obviously use them to kind of sweeten your tea, coffee and milk. Beyond that, don't try to make recipes out of it, because even if you are able to reduce the sugar in a sweet dish, the caloric intake remains higher. So artificial sweeteners made various sweet dishes may be still caloric rich and they can cause damage. So use them for tea, coffee, beverages, that's fine. What are good travel food for people with diabetes? I wish Shraddha had an answer to that. That's a very difficult question, because we have been trying to define diabetes-friendly food in this country, and we have something called as a Blue Dot movement, which we launched 4 years back, and we are trying to establish a guideline of what is called as diabetes-friendly food. We have submitted it to the government as well, that what is a good food for diabetes, but what you get off the shelf in India is abysmal and is poor. So, while traveling, what's a good food? I really don't have an answer. Probably you will have to carry your food from home, but unfortunately what we get commercially in our country does not come close to being a diabetes friendly food. So unfortunately I don't have an answer to that, and probably in some years to come maybe we have answers to all that. Do we have any other questions? So I was talking about diabetes in pregnancy here, and we need to understand that during pregnancy, the motivation of the mother is very high, and probably she takes a lot of pain during pregnancy. But as soon as the child is born, the whole motivation goes away. And people who get diabetes during pregnancy are at a 40 to 50% chance of getting diabetes in the next 5 to 7 years. So it's extremely important that probably pregnancy and diabetes unmasks an underlying metabolic abnormality which can progress towards diabetes. So if you pick up diabetes in pregnancy, make sure that probably yearly I would recommend 6 monthly, that you need to keep your sugars checked, because the progression in our country is very high. And as soon as the child is born, the patient is lost to follow up. They don't follow up at all. And once you have a healthy child, you don't bother about yourself. And we see all these patients after 5 to 7 years with diabetes or complications of diabetes. So once you have gestational diabetes, that's a kind of eye-opener, and it should raise your eyebrows that you probably need to keep checking for blood sugars regularly and make sure that you don't end up with diabetes in the long run. And diabetes, which is diagnosed during pregnancy, is called gestational diabetes. And in 99% of cases, once the child is born, the diabetes goes back and will remit to normalcy. So it's basically the insulin resistance which is there during pregnancy, which kind of progresses a patient from normal glucose to abnormal glucose and gestational diabetes. So once your placental hormones and once the pregnancy is done with and the child is born, the hormonal levels go back to normalcy, and then your sugars also go back to normalcy. It's only in 1 to 1.5% of patients where the patient may progress even after pregnancy to diabetes at the same time. But having said that, we need to monitor these patients regularly and keep a check on them regularly and see that they do not progress towards diabetes in pregnancy. Another complication of diabetes has always been infection, because immunity is something that you can't buy, and diabetes is an immunodeficiency disorder, and your strength to mount antibody response or an immune-mediated attack onto any kind of infection is lower in patients with diabetes. And so diabetic patients are much more common to get complications related to infections. It could be from a mild urinary tract infection to a lung pneumonia to diabetic foot infections. So infection is a major complication in diabetes, and one should know how to prevent infections in diabetes, whether it's foot care in diabetes. For lungs, probably you have vaccinations to prevent infections in the lung. For urinary tract, you have urinary antiseptics and various other methodologies to prevent infections, especially in the elderly and postmenopausal women who are at very high risk for urinary tract infections and genital infections. So genital hygiene, toilet hygiene, urinary antiseptics go a very long way in preventing infections in patients with diabetes, and that's something that one needs to put into practice. And if that's put into practice, we can prevent a lot of infections in diabetes. Apart from these complications, as I said, even liver is a major complication in diabetes, and that's something that we need to take care of. In terms of various other complications, men also suffer from sexual problems related to diabetes, and that's something that we encourage our patients to kind of talk to us. And sexual problems are very high in patients with diabetes, and they come very prematurely, and these can be from loss of libido to erectile dysfunction, and these complications can be treated today, and we have various methodologies of treating erectile problems in patients with diabetes. And it's a huge area which remains unfocused because patients do not complain, and when patients don't complain, the healthcare professional or the doctor doesn't understand the problem. Patient goes through a lot of stress and depression related to that, and these are complications which can be treated today. There are a lot of medications and there are a lot of tests one can do to kind of treat these complications. So it's extremely important that to talk with your doctor, to discuss with your doctor about sexual problems in diabetes, and that's something that we need to take care of. Nerve damage is another complication which is very common in diabetes, where you get sensory and motor nerve-related problems, and loss of sensation is a very common complication, especially in the foot, that you lose some sensation and sometimes you have more sensations, and both these are complications in diabetes. And loss of sensation can prevent you from getting alerted about a small wound or a small trauma or a small prick or something which has hurt your leg, and that can progress into a diabetic foot infection or an ulcer. And all these things can be prevented if we do a lot of foot care and also foot evaluation. Foot evaluation is something that one needs to put in practice, that we need to go to centers which do foot evaluation, where we evaluate the diabetic nerve. We also evaluate the diabetic blood supply into the legs, and also evaluate the pressures which the foot goes into. Because many a time it's the abnormal pressures in the foot which makes it prone to develop callosities or corns, and probably that will progress to a diabetic foot ulcer. And these are things which we can easily identify doing a diabetic foot evaluation. So every diabetic, whether he has a foot problem or doesn't have a foot problem, should do a diabetic foot evaluation yearly. Foot care guidelines should be put into practice whether you have a foot problem or not. Tobacco in any form should be avoided by all diabetics, whether you're a type 1, type 2 or a gestational. Using or choosing appropriate footwear is very important. We keep telling patients that probably you need to buy footwear in the evening, because by that time you have got some swelling in your foot, and probably that's the right size for you. So probably you need to buy footwears which are appropriate, which have a wider front box or a wider toe box. You need to buy footwears which are laced up. You should not buy the slip-on shoes or the narrow front shoes, which probably will put your foot at abnormal pressures. And these can continue and cause a lot of diabetic foot infections and diabetic foot ulcers. So diabetic education or diabetic self-management education encompasses all this, right from foot care to how to manage your blood sugars at home, how to manage sick days at home, how to treat hypoglycemia at home, how to have an algorithm on which you can change your medications and probably up-titrate your dosages and get to a stage where probably we can self-manage a lot of things, how to use a proper structure in kind of checking your blood sugars, and also taking appropriate steps on once you know what way your blood sugars are swinging or the patterns of your blood sugar, then it's very easy for you to kind of change patterns, because pattern adjustment is a very important feature in the treatment of diabetes. You will have patients who have various kinds of patterns. There may be people who eat 1 meal a day, there may be people who eat 5 meals a day, there may be people who eat midnight meals, people who wake up early mornings. So there are people who eat out every day. So it's extremely important that we need to understand the patterns of each patient, and that's extremely important when you go to your doctor, that you need to do a dietary recall on how are your patterns, what are your eating patterns, what are your exercise patterns, what are your sleep patterns, and then discuss with your doctor so that he can give you medications or advice which kind of do not affect your quality of life and does not make you change a lot of things, but they at the same time kind of helping you change a certain patterns, because adjustment of medications is also based on a lot of patterns. So it's very important for that you go and discuss all these things with your doctors, and they would be the right judge to kind of help you change all these things. In diabetes, we have A, B, C in diabetes. A stands for HbA1c. Your HbA1c is a 3-month memory test for blood sugars. It's usually a 10 to 12 week blood test, which gives you an average for your blood sugar for 3 months. It's a gold standard test. It's a surrogate marker for blood sugar control. HbA1c should be done at least 3 monthly for all patients. HbA1c excellent is something below 6.5. 7 to 8 is considered as good. HbA1c more than 8 is poor control, and your fasting PP is not good enough to indicate what is happening in your body. So it's extremely important that you do an HbA1c every 3 monthly and then change your medications based on that. B stands for blood pressure. Almost 75% of all diabetics land up with higher blood pressure, and it's very important that blood pressure and diabetes are kind of two sides of the same coin. So blood pressure needs to be monitored very aggressively. blood pressure for every diabetic should be less than 130/80. If it's consistently more than 140/90, it's time that we start the patients on medications. C stands for cholesterol, and cholesterol is one of the most silent killers world over. And the LDL cholesterol ideally in a diabetic should be less than 70. There are various guidelines on how one should get the cholesterol down, but at least a 50% reduction in the cholesterol will help in the quality of life and in the lifespan of the patient. So A, B, and C is something that we should do very regularly on a follow-up with our doctors. It's just not checking blood sugars, but also blood pressure and cholesterol and cessation of smoking. So if you are able to take care of all these three factors plus reduction in smoking, you can reduce the complications related to diabetes and so many other complications also. So what a diabetic needs is just a good pattern adjustments, checkup of these things, and probably a healthy diet. And a diabetic diet is a healthy diet for the whole family, so there's no need to make a separate diet for patients with diabetes. So the healthy diet that is made is more than sufficient for everyone in the family. And in a nutshell, check your ABC regularly, reduce on your smoking, change your patterns, aerobic activity of 180 minutes per week, and that would help you in preventing the complications of diabetes. I hope I have answered all your queries on diabetes, and hopefully we'll meet again probably on another platform. Thank you so much.